A very good day to you all, and thank you so much for joining us on this TechCabal live event. My name is Adrian Ephraim, and I'm the editor-in-chief of TechCabal, and thank you for joining us here on TechCabal Live. And this week's discussion is around building sustainable financial models for patent medicine vendors. I'd like to welcome you all today, and it's so great to have so many of you today. Just a few words on TechCabal and TechCabal Insights. As many of you know, TechCabal speaks to the business and human impact of tech and innovation in Africa through high-quality articles, reports, and events like this. We also publish the TC Daily newsletter, which is a comprehensive roundup of tech news and events across Africa. And if you're not subscribed, the link will be made available to you in the chat room. So please do go ahead and sign up as soon as you can. You don't want to miss out on our newsletters. This event is organized by TechCabal Insights. It's the events, research, and data analytics arm of TechCabal. And we're an African-focused digital economy consultancy that leverages big data to help startups, investors, operators, and big tech companies to answer the specific questions and implement key interventions. And of course, this event would not be made possible without our sponsors, and we're very pleased to have Solar Center for International Development and Research works, and they work to accelerate positive health, social, and economic reforms through high-quality program design and implementation, capacity building, and through scientific research and knowledge. I'd like to just run you through the agenda for today. If we can put that up on the screen. Okay, so just to take you through the agenda, we will first be having a presentation by the Solina group, followed by a discussion for around half an hour. You will, as the audience, get to ask some interesting questions to our panelists, and then we will have some closing remarks before we end off the day. So looking forward to a really robust conversation. I'd like to introduce my chat room moderator, Victoria, who's on standby to moderate the chat room. If you do have any questions, please do feel free to pop them in there, and we will most certainly ask them to the panelists. It's my pleasure now to introduce to you Efoza Omoregi from the Solina Group, who will walk us through the report and what the Solina Group is all about. And Efoza, it's a pleasure to have you here, and I hand it over to you.
Thank you so much. Good day, everyone. I'm happy to be here. My name is Efoza Omoregi. I'm a manager with Solina Group. And today I'll be walking us through the context, setting the context right for this webinar, while we go on to discuss how we can actually improve and create that sustainable financing mechanisms for PPMVs. Maybe a little bit of background about Solina. We're a health system consulting firm, and our goal is to optimize health outcomes globally. And research is also a core component of what we do, and happy to engage further. So on this, we'll be discussing building innovative and sustainable financing for PPMVs. Please, next slide. Some context of something we are very much aware is that the health system in Nigeria is still facing a lot of challenges, right? So we have a good proportion of the population that still do not have access to quality health services. There are different issues around infrastructure, human resource, funding have all led to this weak health system that we have. The PPMVs, which are the patent and proprietary medicine vendors, actually do play a crucial role in improving access to health services. In fact, they are the first point of contact for a lot of illnesses, and in some cases, we find out that they are maybe even the only point of contact in some very underserved and rural areas. And so they have the potential to actually play a good part in improving our overall health system in Nigeria and improve health outcomes. Because of they are not being regulated by PCA, there's a huge opportunity for them to actually serve this purpose. And so over the course of today, this presentation and the other panel discussion will be exploring how we can build out the sustainable financing mechanisms for these PPMVs. Next. So I think the first question to answer is, who are PPMVs, right? Who are the patent and proprietary medicine vendors? right? For those who don't know, they are people that are defined as they do not have formal training in pharmacy, but they do sell medication and pharmaceutical products on a retail basis for profit, right? Those of us are very familiar with the terminology we used to use, which is not the wrong term. We call them chemists, right? Those local chemists beside us, but they are called PPMVs, patent and proprietary medicine vendors. And we have a lot of them scattered around the country. They're regulated by the Pharmacists Council of Nigeria, the PCN, whose role is to make sure they actually meets their quality. They have an association that goes very strong, the National Association of Patent Proprietary Medicine Dealers. And this has very strong presence across the 36 plus one states and even at the LGA levels. They provide services that include selling over the counter drugs and commodities, referrals, and also depending on the tiers that we'll discuss in the next slide, also provide some services. It's estimated that there are over 200,000 of these PPMVs currently operating in Nigeria, and that number continues to grow. Next, in terms of the tiers, this just gives us the scope of work as defined by the Pharmacists Council of Nigeria that the PPMVs can actually offer. There are three tiers. So we have tier 1, 2, and tier 3. For tier 1, there are those that do not have the adequate health qualifications. And so there are some criteria and they're able to read and write, their age and references. But in terms of the scope of what they are able to do, is selling over the counter medication that includes a number of things and also offer services like FP services like condoms, selling condoms, cycle beads, emergency contraceptives, and refill of pills but not initiation. And in some cases where the training have actually carried out, they can actually then do the RLDT test. For the tier 2, there are those that they have health qualifications, so they include those that have possess a diploma, a degree in nursing, midwifery, or community health extension workers, community health officers, as the case may be. And then they are able to provide more services that include the RDT test, HIV self-testing, self-injecting contraceptive, and in a lot of cases, able to even provide LACs, long-acting reversible contraceptives like implants and the likes. While it's here, three PPMVs, still with health qualification, but what differentiates them is really that they must be pharmacy technicians and they can provide a suite of services as well, very similar to tier 2. That includes HIV self-testing, self-injection contraceptives, and referrals, the case may be. Next. For PPMVs, there are lots of challenges that they face in providing their services. This is not in any way exhaustive, but highlight a few that are critical. First is that they have some inadequate regulation and monitoring, which is the problem that PCN seeks to solve in actually regulating the quality and safety of what they do through the tiered system, and also training them as well. Secondly, is limited access to credit and financial resources for them to expand their businesses, invest in infrastructure, and also improve the range of services that they offer. And this is kind of like the focus of what we'll be discussing today, is providing that sustainable financing base for these PPMVs. Other challenges include the lack of sufficient training. Of course, they don't have the adequate training, and so the ability to treat all these medical conditions effectively is actually worrisome. Also, difficulties in assessing cost and supply of quality commodities also affects the affordability and even availability of these medications at these PPMVs. So you get things like stockouts and availability of commodities at that level. There are also issues around multiple and high rates of their charges, regulatory charges, things like taxation and the likes, and that ultimately increases the operational cost and also financial drain, their profitability as a whole, and they are want to business. And lastly, there's some challenge around the lack of access to modern information technology tools, IT tools, making it difficult to keep records and also implement digital healthcare solutions. Of course, narrowing down on financing, which is a big challenge, is what we'll be discussing and asking questions around today. Next. Also, to shed more light around the financing problem, Solina conducted some study to develop a strong value proposition for PPMVs to join the three-tiered accreditation program, which I discussed earlier, that ultimately will improve the quality of services they offer, their regulation. And for this, we surveyed almost 400 PPMVs across 7 states and asked specifically what would be an incentive for them to be part of this tiered accreditation program. And interestingly, most of them, nearly 60% of all the PPMs that we sampled said access to loans and grants would be their most preferred incentives to join or continue the accreditation program. Again, just pointing back to what we know is access to finance, access to credit remains a challenge for them. And it's not only a need that we need to solve, but even an incentive for them to continue to be on this program to improve quality and serve the populace. Next slide. So lastly, just landing back on the initial question we started from, which is how can we actually build this innovative and sustainable financing for patented medicine vendors? Some key considerations for us here is the fact that they offer a broad range of services, they need access to finance. We know that. I would say that microcredit actually have worked in various clients because for PPMs, for their structure, they actually need small loans. They are qualified as SMEs, right? So they don't need the big loans. But they also challenge around if they can meet the requirement to access loans from our traditional financial institutions. There are various programs that try to solve this problem, but clearly we know that with access to finance, they can increase their business revenue, the quality and quantity of their products. Also to mention that there might be need for some training on financial management, which is relevant to us, not just the fact that they need access to the loan, they don't need requirements for that purpose. So I'll pause here and hand over back to you, Thank you very much.
Thank you so much. It's fascinating. I think we've got so much to unpack, and we're very fortunate to have such an esteemed panel here today to help us unpack and dissect some of the information that you've just shared with us and some of the challenges and the issues that the industry is faced with. I'd like to take a few minutes now to introduce our panelists, and in no particular order. Let's start with Emeka Okafor. He's a seasoned private health sector engagement expert with 19 plus years of experience in managing complex public health interventions in Nigeria. And his expertise covers private sector engagement, social marketing, community mobilization, procurement, and supply chain management. It's a pleasure to have you here, Emeka. Next up, we've got Michael. Michael is a private sector expert with Michael Alagbile. He's a private sector expert with over 20 years of work experience in public health and pharmaceutical supply chain. And his areas of expertise include program management, private sector engagement, health policy design, and health system strengthening. It's a pleasure to have you here, Michael. We've also got Kwesi Arhin, who's the Senior VP for Retail Operations at award-winning health tech company mPharma. And he oversees strategic planning and business execution in Nigeria, expanding the retail footprint and commercial impact. We've also got Charity Ukwo Abah. Charity is the Deputy Director of the Enterprise Development and Promotion Department at the Small and Medium Enterprise Development Agency of Nigeria. And that's a governmental agency that coordinates, facilitates, and promotes micro, small, and medium enterprises in Nigeria. Pleasure to have you here too, Charity. Welcome. And last but not least, we've got Victor Benjamin. Victor is the co-founder and COO of Remedial Health, an organization that leverages tech and improves affordability and accessibility to authentic medicines for healthcare service providers across Africa. Gentlemen and lady, very warm welcome to you all.
Thank you.
I just want to set the scene a little bit. Each year, I mean, less than half of Africa's citizens have access to healthcare, the healthcare that they need. And this is according to the Africa Health Agenda International Conference. This was a report that was released there about 2 years ago. And each year, approximately 97 million Africans, that's about 8.2% of the population, incur catastrophic healthcare costs. Particularly in countries like Nigeria, Sierra Leone, Egypt, and Morocco. And about 15 million people will be pushed into poverty each year because of these out-of-pocket costs. Basically, the cost of healthcare in Africa is high, leaves a lot of people locked out of accessing proper healthcare. And that kind of brings us to the kind of theme of today, where we're discussing building innovative and sustainable financing for patent medicine vendors, the PPMVs, as Efosa has described. And now the first question I have would go to Charity and perhaps Emeka as well. We've just heard what an important and essential role that PPMVs play in increasing healthcare services to communities in Africa. In Nigeria, over 50% of the population visits PPMVs for treatment for symptoms of malaria. And yet PPMVs battle to get credit financing. Charity and Emeka, I'll go for Charity first. What are the reasons for some of this?
Yeah, thank you very much for that question. I guess to start with, just like you saw in the earlier slide, the PPMVs are informal private sector providers. So most of their outlets or most of their operations are done informally. Most of the time they don't have bank accounts. Some of them register their businesses but not incorporated, so they are unable to set up bank accounts, and they take out monies from their business to run their daily lives, which again the bank consider a big risk to invest, and because of that too, quite a lot of them also have poor financial management skills. So again, that's the bank find very unattractive to invest. So again, you also find quite a lot of them, located in areas where there are no banks. So most of their transactions are cash transactions. So I would say a good number of them are excluded from the formal banking transaction and formal, the traditional financial institutions. So that again has limited, both access and also the opportunity for them to also get loans from conventional banks. So I think the structure of their business, the informal nature of their business, seem to also contribute to this.
Yeah, I mean, and as a follow-up to that, perhaps Michael can jump in here. Some of the major reasons for this lack of access to finance for PPMVs has been, as Emeka has hinted to, perhaps a lack of trust, as some of the formal banking institutions maybe are grappling with the risk credibility of PPMVs. What can be done to address this lack of trust in PPMVs?
Thank you very much. Like you rightly said, the cost of giving loans to PPMV by their informal nature is very high. So financial institutions, most times, even where they want to give those loans, it comes at a premium. So basically, approaches that has been used to mitigate some of those challenges, the risks, to build those trusts is using the collective mechanism. When Efosa was presenting, he talked about the group, NAPMED, which is the umbrella association. So that group, most times where things have worked, that umbrella organization serves to mitigate the adverse effect of giving loans to individuals. So the group will come in as an umbrella body and then are able to intercede on behalf of their members. Also, in some other instances, we can also have the peer-to-peer. So instead of working with individual PPMVs, we can have a group of maybe 5 or 6 PPMVs coming together to access those services. And then we can also leverage digital services here to improve that trust. We have things that has been done in other climes, such as leveraging digital platform to provide some form of working capitals to PPMVs. And by so doing, they're able to have a footprint, a digital footprint that potential financial institutions can tap into. For example, in Kenya, we had MasterCard, we had Unilever, we also had the Commercial Bank of Kenya coming together to run a scheme where they provide some form of working capitals to retail, small, informal businesses. They're able to track the distribution and the inventory and the uptake of those commodities. And those data is now passed on to the bank to say, look, this is the turnover of this retail outlet. So that in itself helps to build trust, and then you get to know the capacity of each provider to say, well, this, so in essence, those data that are not available in real life, we're able to get them if you're able to leverage digital, and that will help to build trust and also reduce the overall cost of providing loans to informal businesses. Thank you.
Thank you, Michael. Yeah, that's really interesting. I think, you know, PPMVs are said to perhaps possess maybe lower educational qualities, and yet they are so integral and so integrated to where the source and the need of healthcare is in the rural areas and in hard to reach areas. But how can we more effectively integrate them into the national youth system, into the national health system, to realize the full potential of the sector? Kwesi, do you have perhaps some thoughts around that?
Yeah, thanks, Adrian. I think for most of what Michael and Efosa and Emeka have said, generally aligned with what they said. Unfortunately, it's actually more than what we have currently. I was reading an article earlier where it says we have over 600,000 PPMVs scattered all across Nigeria, right? But when you look at the registered list from PCN for last year, it's just about 22,000, which is less than 1% of the actual number of PPMVs we have. So in actual sense, we do not even know the full number that we are dealing with, right? So that's one major thing that we need to look at. And I feel like this is where mPharma tried to come in. In 2019, we had this program with Bill Gates Foundation, Bill and Melinda Gates Foundation, with SFH and IntregratE to sort of pilot a program with these PPMVs. So we selected about 20 of these PPMVs and sort of went into a partnership with them, where we provided them with refurbishments, we provided them with products or drugs, registered of course, and also gave them our Bloom software. The Bloom software is our own proprietary software that was developed by mPharma, and it's being used in these PPMVs. Since 2019 to date, we've actually expanded the scope to almost 200 PPMVs. So in all these PPMVs, we give them this working capital, interest-free, of course, but that money is actually used for the refurbishment, drugs. We give them laptops or tablets for them to use. We offer them customer service training. We offer them business financing training and all that. And what we've also sought to do is to help them in their marketing works. So for example, we do health screenings every quarter for these PPMVs, you know, just to drive more traffic and footfall for them to be able to generate more revenue. Also, we have a separate program for pharmacies that we have, and we've tried to join that with our PPMV initiative. So PPMVs are able to refer patients to these pharmacies. So that's how we try to integrate both PPMV and pharmacies. And then we've gone a step further to place, we have a program called Multi-Doctor, where we've placed telemedicine devices in some of these PPMVs. So any patient can actually walk into these PPMVs and speak with a doctor virtually. We also have healthcare professionals in these PPMVs as well. So it's sort of a whole ecosystem of the health sector where you can enter a PPMV, speak to a doctor, speak to a nurse, speak for pharmacists potentially, if you are referred to another pharmacy within our network. So that's some of the ways we try to integrate the whole PPMV framework into the healthcare.
Thanks for that, Chris. I'm not sure if Emeka, if you have anything to add to that, or Michael.
Yeah, I'll just chime in. You know, we started on the IntregratE project as a pilot in 2017, where we worked very closely with the Pharmacists Council of Nigeria to pilot the 3-tier accreditation system, which essentially is to structure the training of the PPMV, targeting each of the tier for a more tailored and appropriate family planning and peace. And then a very crucial part of that intervention was to also create linkage such that when PPMVs are being trained, you know, they remain within their scope. And then they also refer to either a higher tier of PPMV, a community pharmacist, or a PAC. So each of the PPMV is mapped around a secondary or a primary level provider. And then, of course, these referrals are happening. So that's also a way to integrate them into the formal sector. And again, we also found that a lot of data coming from the private sector, particularly the PPMVs and the community pharmacies, are not visible in the national instance. So again, that was a huge problem. So government is budgeting primarily based on the information they are getting from the public sector, which excludes almost 60% of where majority of Nigerians, you know, access care, which is the PPMV. So we felt that that wasn't good enough. So in the states where we started piloting, what we did was to work with the Federal Ministry of Health to integrate PPMVs into community health management information system. So a lot of the PPMV that we are working with on the IntregratE project now are now reporting their data into that system. So again, that's also integrating them into the formal sector. So we have seen quite a lot of positive from that integration. Data from the PPMVs can now be seen on the national instance. So you can now say, okay, PPMVs are contributing X, you know, number, you know, in terms of the data, in terms of the services that they are providing. And this is just for a few select PPMVs in the 2 states and now by extension, the 9 states that we are working in now. So you can imagine what it will be when you engage over 200,000 PPMVs that are currently operating in the country and getting their data to feed into that system. Then you'll be able to plan appropriately.
Yeah, that's quite interesting. I mean, the question of integration, but then also the question of inclusion, and there are limits to what PPMVs are, the kind of services that they're able to administer. A question for Michael, and perhaps Victor, if you want to chime in, you're welcome to. I mean, are there plans in place to update policies to expand the kind of services that PPMVs are able to offer?
Well, thank you. Basically, that is the core premise on which the 3-tiered accreditation system of the Pharmacy Council of Nigeria is built. That's the very foundation. So in that, in the 3-tiered accreditation system, which IntregratE project is currently piloting, the PPMV has been segregated into 3 different compartments, just like Efosa said. And we've gone ahead to work with the Federal Ministry of Health, the Pharmacists Council, and other stakeholders now to revise the tax shifting cash sharing policy. So there is a recently updated version of that policy document that allows PPMVs, especially the medically trained one referred to Tier 2, and the pharmacy technicians in Tier 3, to do more than their traditional scope. So the whole gamut of services now that the law allows PPMVs to provide, and that in itself is opening up the space for that group of providers. Beyond that, we've gone ahead also to work with the Federal Ministry and the Pharmacists Council to develop specific checklists and training manuals that are currently being used to build the capacity of these providers. Because again, before they can provide even the expanded scope, they will need to be trained and their capacity built. So that is currently ongoing at the national level in about 11 states, where we are training these PPMVs using that specially designed manual. And then there is also a specific checklist that has been put in place, developed in conjunction with the government, to be able to monitor the quality of the services that they are providing. So overall, there are a lot of activities that are currently going. One other leg of that work is also the revision of the approved patent medicine list, because again, that is like another policy document that lists those health commodities that the PPMVs are allowed to carry. That has also been revised and expanded to include DMPASC, also always referred to as Sahana Press. So the tier 2 PPMVs are now allowed to stock and provide those services. Thank you.
Thank you, Michael. I just want to bring in Victor here. Victor, in your experience, what support do you think, having heard what you've heard even now and in your own experience, what support do you think PPMVs need?
Okay, thank you, Andran, for having me. So I want to state that I can't agree less with what other speakers have been saying. So I would want to build from what Michael just said. I think there's a major gap that exists in what PPMVs do in the various localities that they are located. Whether we agree or yes, they constitute a major part of drug distribution and dispensing to the average Nigerian patient. This figure is such a wide one that you don't want to ignore. What I think can be done is there has to be a lot of enlightenment programs. And I feel that the umbrella body, the NAPMED, is greatly underutilized. I've been opportune to be at different meetings where they have their monthly meetings, some their bi-monthly meetings. And I have also looked at the content of such meetings. It's really alarming, because there's just a lot that has to be done in educating these PPMVs on what they need to do. From what Michael said, there's a huge gap in real-time data. It doesn't exist. A lot of them, as a matter of fact, it is less than 10% that are actually registered. These PPMVs in the various localities that they are located are known by the association, by the executives of this association. There is no system put in place to work with the executives of this association, first of all, to get these PPMVs duly registered. Let's have real-time data. Let's get to know the number of patients that you service on a daily basis, where these things can be collected, and then the health regulatory bodies can make well-informed decisions from those data. This is non-existent. That is a huge gap, and that is a major support that needs to be unleashed to the NAPMED Association across the entire 36 states, and even the FCT as well. Again, there still needs to be sensitization. Most PPMVs also don't even get to understand, they don't even know the scope of formulary that they should dispense. When you go to these associations, issues being discussed there are non-existent. they don't improve the life of the average Nigerian. And this is quite worrisome. So I think the kind of support that we need is, first of all, proper enlightenment, partnership with the NAPMED to address these issues, these fundamental issues. And then in general, we can improve the quality of healthcare delivery at a basic level. Thank you.
Thank you so much, Victor. Appreciate that. I'd love to bring in Charity now. Welcome, Charity. It's good to have you here. We heard earlier from Michael around the lack of access to financial institutions from the PPMV side. What are the criteria or requirements that financial institutions typically consider when assessing credit applications from PPMVs?
Very much. For PPMVs to be able to assess financial credit, certain basic requirements are needed. You must have a good business plan. It is very important that you have a big business plan. And the business plan is a complete description of what you intend to do, that you are presenting to the financial institution. It is a clear roadmap that guides what you want to do in the business. And it is directed towards, it's going to be a guide for you to be able to present your idea vividly and perfectly to the financial institution. A detailed description of what you want to do, what you intend to do. Added to that also is the responsibility you have to register your business with the regulatory bodies, because in that case, it means you are supposed to formalize your businesses, because no financial creditor is ready to give you financial assistance when your businesses are not formalized. Formalization of your business is a kind of identification, is a means of identifying that you are in existence. You can be reached. You have an address where you can be reached. You know, in area of formalization also has to do with opening a bank account. You must have a bank account, and good record keeping is also required for you to be able to access financial, for you to be able to access microcredit. You must also have the managerial ability to be able to manage the fund that is going to be given to you, because no financial institution is ready to give funds to an enterprise that will not be able to manage the business properly. So let me say that, one, a good business plan. Two, you must have a registered you must have a registered business name. You must have the capacity to be able to handle the fund that is going to be given to you. You must have character, that the financial institution giving you the credit should be able to have confidence that at the end of the day, you will be able to pay back the money that is given to you. That confidence must be built in the financial institution that is giving you the credit facility. Otherwise, there won't be much headway for you assessing the loan. Thank you.
Thank you, Charity. Just a reminder to our audience that you can ask your questions in the chat if you have a chance. It'd be great to hear from you, and we will pose them to the panelists. So please do take advantage of that. We've got just a few more minutes now left for this discussion before I kind of ask some of the audience questions. A question for Kwesi and Michael. 6 in 10 Nigerians lack access to formal healthcare. How can we build infrastructure and links between PPMVs and the formal health facilities to kind of bridge the healthcare gap in this country, in Nigeria?
Yes, so thank you very much. That's precisely what IntregratE is on at the current moment. We're trying to create a handshake between the pharmaceutical private sector and the public sector in a way that it will improve overall health coverage. And we are using some of the best approaches in the textbook. We are working with government. So we are trying to improve government governance, oversight of the whole health system. Like Emeka said at the beginning, the job of government is to manage both the public and the private sector health system, and not just the public. So our work is to build capacity of government through regulation, through monitoring and oversight, to ensure that the services of the private providers, especially the PPMVs and the community pharmacists, are in lines with national guidelines. We are also working in a way that there is an exchange of information between the two sides. So Emeka talked about it. We are reporting data to the national level. It's giving some form of visibility to the existence of the private sector, especially the PPMVs. One major reason why the oversight or integration of the public and the private sector into the public sector work has been lack of information and lack of clear understanding of what the private sector stands for and the benefit that the country stands to gain by integrating the private system into the public health system. So providing that information to policymakers through series of policy dialogue engagement that we undertake on the IntregratE project is also helping to bring some form of understanding, clarity to ways of working. We are also there is also improvement in even the regulation. Like Kwesi said at the beginning, he said there are about 600,000, only 222,000 of them registered last year in PCN. Yes, but that number is on the rise now, basically because of some of the work that we are doing with the council. The mandatory entry point training program, which is part of the tiered accreditation system, has helped to create awareness among PPMVs on the need to come under the umbrella of the regulator. So last year we had over 110,000 PPMVs now registering presenting themselves to PCN to be registered. So a whole lot of engagement, but ultimately the goal is to ensure that we improve the contribution of the private sector, especially the PPMVs, to healthcare provision in Nigeria. Thank you.
Thank you, Michael. Kwesi, do you have anything to add to that?
Yes, just to add, I think it's also important for us to address the negative perception, first of all, that people have about PPMVs. You know, they are sometimes perceived as quacks, in quotes, due to some of the issues that have been highlighted. So I think PCN and maybe those in the healthcare industry can do more in terms of education to help with this. And also, I agree 100% with Michael when he says that the private sector will be the engine of growth for this. For us at mPharma, I mentioned earlier, what we've tried to do in terms of infrastructure and building that bridge or closing that gap is using our software. Because imagine going to a PPMV who initially did not even record sales, and then jumping from someone not taking sales to now using a laptop or a tablet to record sales, do analysis, get data, know what to order at the end of the month and all that. So it's quite a huge jump, almost from 0 to 100. And I believe that the private sector can help in facilitating this. So I mean, including, just to add to what Michael said, it's something we also need to consider.
Fantastic. Thank you, Kwesi. I've got a couple of questions from the audience now, if I can just switch a little bit. Question from Ekete Akono. There's a plan on ground for utilization of PPMVs in the community distribution of misoprostol in Nigeria. Will the pricing of this essential maternal commodity be regulated to have the same price tag across the board? Not sure who wants to take that question. The question around pricing of a very important maternal commodity.
Okay, I think I can jump in. The PPMVs are the private sector, and sometimes I think the misunderstanding of how PPMVs operate is usually the problem, because some people think that the PPMVs are paid by somebody else. Mm-hmm. These are people who are there for business. So recognizing that will also mean that, yes, they may not be as profitable as the pharmacies, of course, because they address a different segment of the population. So I can guarantee you that you may not be able to achieve the same price across the PPMVs, but you will get, you know, a reasonable price. Again, depending on how they get the misoprostol. If they get the misoprostol fairly cheap, I can tell you that it will still be very affordable because of the kind of clients that they service.
Thank you, Emeka. Another question from Damien. Do PPMVs dispense on behalf of hospitals? In other words, can a hospital that doesn't operate an on-site pharmacy refer patients to PPMVs? Anyone want to jump in on that question?
Yes, let me also jump in. Unfortunately not, in the sense that PPMVs are restricted in terms of the scope that they can operate, both the scope of medicine, and that's why they have, you know, a list called the approved patent medicines list, which is very restrictive. It's majorly over-the-counter medicine. So when you talk about antibiotics are clearly away from their scope. So they will never be able to dispense on behalf of the hospitals. But what we have seen, interestingly, is that especially as you go further north, you will find some communities where there are no PACs, there are no pharmacies. The only thing that you find there are PPMVs. You know, so what we try to do is, as much as possible, to train them to be able to identify those basic illnesses and also the signs of severe illnesses for referral purposes, so that they don't begin to go beyond their scope. So again, it's not a straightforward answer that one can give, because the way the health system is in Nigeria is very dysfunctional. A lot of things are not in place. Lots of communities don't have access to even the primary healthcare system. So you can see people traveling as much as 2 hours to be able to access a public functional PACs.
Okay. Victor, you look like you wanted to chip in there. I'm not sure if you have anything to add, but please do if you.
So I think I quite agree with what he said. And the healthcare delivery system actually in Nigeria is in disarray. So you can't say this is it for you. If you have your prescription list, you can't say this is where I am to source this medication. So fortunately, if you're lucky enough, you can find that those prescriptions, the medications on that list are available at the PPMV. Fine, you can source it from there. If not, you just have to refer to a pharmacy nearby.
Thank you, Victor.
Yeah.
Another audience question from Olwaleke. The PPMVs, with PPMVs limited sophistication is what makes them readily available in the remotest parts of the country. Given their lack of sophistication, such as bank accounts, incorporated stores, and financial literacy, the question is, how can we meet their financial needs and then transition them to where we want them to be? Perhaps maybe Charity or if anyone else wants to jump in.
Well, I will start, then I will allow Charity to also chime in. I think this is actually why we're having this conversation. The PPMVs are providing, a significant level of basic healthcare services. Their presence is filling a gap. And we know all the issues that they face because of the informal nature of their business. So the conversation is, how do we move them from where they are to where we want them to be? And we've said the first thing is look at structuring some kind of training for them on PAC services, which is what we are achieving through the tiered accreditation system. Then the second one will be, how do we also structure financial management trainings for them, business management training, just like Charity said. A lot of them start out without even thinking about business plan. They don't have business plan, they don't have bank accounts. So how do we train them? How do we enlighten them? How do we bring them to know the importance of having those? A lot of them keep sales record, but these sales records are not structured. Sometimes they write it in exercise books. So you can't even look at a trend. For instance, you can monitor what they sold this month versus what they are selling next month and all that. So it doesn't tell any story. So how can we build in some inventory system like what mPharma is doing with the Bloom? How can we structure some events or record keeping, be it electronic or something a bit more robust that can tell some stories? So these are some of the things that we are thinking about, even as we expand, the IntregratE project to some states. But again, the issue is that the IntregratE project is just working with some little fraction of the PPMV. There's a whole lot that still can be done.
Okay, just to add to what Emeka said in terms of inventory management. Sorry, let me jump on this. So at Remedial Health, we also have an inventory management system that is linked up with most of these PPMVs that are signed up on our platform. So we help them track these metrics from their day-to-day sales. So we track their inventory, and it can also guide them or suggest to them what's next that needs to be stocked and what items you need to increase your quantity in your next purchase and all of that. So we have an inventory management app that's synced to the daily operations of this PPMV. So that is in place, and we are pushing it, trying to solve this issue. Thank you.
Thank you, Victor. Charity?
Yeah, my agency, SMEDAN, was established to promote the development of micro, small, and medium enterprises, MSME sectors of the Nigerian economy. We are to stand as a one-stop shop for MSME development. One of our core mandates is entrepreneurship training and development for sectors like the PPMC, like this. So my take here is that there could be a kind of collaboration, with relevant agency like my own SMEDAN, where these PPMVs could be trained so that they will have their act of being able to manage businesses, have the managerial capacity to manage businesses well. In SMEDAN, we also have certain intervention programs, like the CGS, Conditional Grant Scheme, where we, look at enterprises that are the bottom of the pyramids. We advance certain credit facilities to them to enable them to increase their to enable them to increase their sales and things like that. We inject so that they can inject the money to help in the financial capacity of their businesses. So I am saying here that we can liaise with relevant sister agencies like SMEDAN for managerial training, capacity, skill development, registration with CAC can also make them to formalize their businesses.
Thank you, Charity. Just a reminder to our audience, we will be putting up a poll very soon. My colleagues from TC Insights will be putting up a poll very soon, and I encourage you to take part in that poll and give us your opinion. It's really, really important. You'll see it on your screen right about now. Another question from Ganyu Memudu. How do you control the problem of fake or substandard drugs in these PPMV stores? Not sure who wants to jump on that one, maybe Kwesi or yeah, Emeka.
Okay, let me jump on that. Okay, go ahead, please.
Okay, thanks so very much. I think this question keeps coming up all the time. Part of what the IntregratE project is also working with the Pharmacy Council to pilot is what we call the hub and spoke supervision model, where we are getting a pharmacist to supervise a number of PPMVs in a cluster. And then, of course, part of what they are supposed to do is to be able to look at where the PPMVs source some of their medicines. And interestingly, this has thrown up quite a lot of issues. I will tell you, I'm currently talking from Kano, and I will tell you that in the review of the hub and spoke that we just had with the Pharmacists Council and some of the pharmacists acting as hub, we are beginning to see a new drug market emerging in Kano. And Pharmacists Council of Nigeria would not have known about this without, that hub and spoke model, bringing regulation closer to the PPMVs. So one good thing about the hub and spoke model is that, a pharmacist is supervising about 10 to 15 PPMVs. So he's bringing regulation closer to the PPMVs, looking at what they are supposed to stock, whether they are stocking drugs that are within their scope, looking at the quality of drugs that they are stocking, even the storage condition of the drugs within the PPMV. Also looking at, whether they are stocking drugs that are already expired, drugs that are registered by NAFDAC, or so these are, putting them in check, sort of, But again, this is still at the pilot stage because we only have about 4 clusters we are piloting 8 clusters in Kano. 4 in Lagos, 4 in Kaduna, and 8 in Gombe. So this is a way of bringing, regulation closer to the PPMVs. And as part of the training, the mandatory entry point training program that Mike talked about, which you also call the tiered accreditation, there's a whole module that talks about quality of medicines, how to, first of all, identify fake drugs by looking at the features. Of course, the PPMVs and even the pharmacists cannot test, drug sample. For you to test drug sample for quality, you have to assay it. It's only NAFDAC that can do that. However, there are other physical features that you can use to know whether this drug is fake or not. You look at the labeling, you look at the constitution of the drugs, whether there are drugs that are supposed to be in suspension that it has already started kicking. You also look at the expiration of the drug. There are so many things. Again, the purpose of that is to equip the PPMV with the right knowledge so that even at the point of making a decision to buy a particular medicine, they will use that skills to assess the medicine to see if by physically looking at the medicine, it could be fake or not fake before even making an attempt. And then we're also encouraging them to buy only from registered pharmacies, registered wholesale pharmacies, and keep the receipts. So that way, again, whatever medicines that are stocked within the PPMV can be traced to the source. Over.
Okay, thank you. Just to add to what he said, the spread of counterfeit and substandard medicine in the Nigerian open market is such a big and a worrisome one. As it is, the distribution system in Nigeria is very porous. Entrance into this market, substandard medicines, counterfeit medicines coming into this market, because of the porosity of our market, it's very, very open for this product to get into the market. So the distribution system, the way it is right now in Nigeria is most of these PPMVs, they source their medications from the open market. And these counterfeit and substandard medications can also gain entrance easily into this open market in such a way that it becomes very difficult for you, even as an experienced medicine vendor, to differentiate which is authentic and which is fake. Just like he just mentioned just now, that there are ways to check for these confirmations to know if these medications are even actually genuine or they are fake. One thing we have taken up on ourselves at Remedial Health to tackle is the spread of counterfeit medications in Nigeria. So what we are doing is we have an app that is an integrative system where we link manufacturers or importers of these medications to frontline healthcare providers in the PPMV space. So there is no access for a counterfeit or a substandard medication to penetrate into the market. So we deal with the manufacturers and the importers directly. We make all of these medications accessible on our platform, and then the PPMVs, from the comfort of their jobs, can leverage digitally on our apps, order for these medications. We will see it at the back end in real time. We deliver to their doorstep, regardless of your location in Nigeria. Presently, we're in all of Nigeria doing this. We deliver those medications to your doorstep. So we ensure that authenticity and affordability is made accessible to the PPMV stores. So that is what we have been doing, and most of the platforms subscribed, most of the outlets subscribed on our platform are enjoying this privilege. So free delivery, you have that leverage to order from your location, and then we'll hand it over to you. By so we are curbing the spread of counterfeit and substandard medications that exist in the open market. Thank you.
Adrian, just
go for it, Kwesi.
So I think for us at mPharma, we have, I guess, taken the more difficult approach where we totally manage the inventory for our PPMVs in our network. So right from beginning to end, where we source the drugs and then place them in the shops for the owners. So we've cut out that risk of counterfeit or expiries and all that, because we also bear the risk of expiry. So once the product expires in the PPMVs, we go there to withdraw them and then send for destruction. So we deal with all that at the front end, and then they just do the selling. So that's
very hands-on approach there. Presumably, like the proliferation of substandard drugs, fake drugs, has to do with cost. So a question from Anonymous is, what can PPMVs do to ensure access to these commodities at lower prices so that they could pass this on to their customers? That's probably the golden question for everyone.
So maybe I'll jump on this. Presently, the distribution chain in Nigeria has too many middlemen. And because these medications move from one middleman to another middleman, sometimes to 3 or 4 middlemen before it gets to the PPMV, it makes access to these medications overpriced. Because any medication that passes through you, of course, you want to move it on at a margin. You want to make some profit out of it. That is just the norm. That is what exists today. And so by the time it gets to these PPMVs, who are at the frontline space, that have a day-to-day interaction, interface with the patients, these medications become overpriced. What we are doing is, we are just that one link between the manufacturers and the PPMVs. So we are cutting the too many middlemen and the overpricing that could result from that. So just one link on a digital platform, you can see these medications in real time. You see the prices, very competitive, good prices. You order these medications, the quantity that you need. You plug into our inventory app management system, will deliver to your doorstep in no distant time. So by so doing, we are trying to get overpriced medications out of the space and reducing the too many profits for too many middlemen that exist in the chain. That is what we do. Thank you.
Thank you, Victor. Another audience question here from Kama Kamzi. I'm curious as to what degree of specialization should a PPMV vendor obtain before giving out services to the community? Perhaps Charity or Michael, perhaps? Anyone could jump in.
Come again, please.
The question is, what degree of specialization should a PPMV vendor obtain before giving out services to a community?
Well, again, like we said before now, it depends on the tier of the PPMVs. Okay. So we have 3 different tiers, and each of the tiers has a mandate of what services they can offer. But one thing that is clear is that for PPMVs to offer the kind of services that is in consonant with approved standards, we need to build the capacity. And that is what most of the speakers on this webinar has talked about. The quality of services provided is currently, I would say, unregulated. You can't really say it's bad or it's poor. So, and that is one key drive of the PCN tiered accreditation system, to help improve the quality through capacity building. And that is already ongoing. As to how far they can go in specialization, again, that is limited by the regulator. So there is a clear guideline of how far they can go. And as it is today, that guideline is hinged on the National Tax Shifting Tax Sharing Policy. So everything that a PPMV is allowed to do is listed in that document. The only thing we have seen is that on this move, on this journey, they are beginning to do more than their traditional role. And that is something good for the country. So they are able to provide more services to a larger segment of the population. And that is ultimately helping to improve their contribution to the overall health coverage in Nigeria. Thank you.
I want to quickly add to what Michael has just said. I understand from what he said that there are specific areas, there are 3 tiers of areas where the PPMVs can operate from. I'd like to also add quickly that for the regulators of the PPMVs, I think there is need for need assessment, training in that area, need assessment, questionnaires given to them, and from the data gotten from these questionnaires, and then training can be tailored along their needs so that it can improve their services to the consumers.
Thank you very much, Charity. One member of our audience, Opemipo, has a question on clarity. What is the name of the app for detecting counterfeit and fake drugs? I'm not sure if Emeka or Victor mentioned it. The name of the app for detecting counterfeit and fake drugs. I'm not sure who mentioned it. Was it you, Emeka?
Okay, well, I'm not sure anybody actually mentioned an app, but in case if he wants to know, there's an app called Check It.
Check It.
Check It. So I'm not advertising for them anyway, but to say that Check It also is some kind of a platform that where the manufacturers of common medicines list all their medicines, including the features to identify which one is fake, the batch numbers, the expiration dates, and all that. So if a PPMV has the app, the Check It app, and then he's about to purchase a medicine, he can actually cross-check whether this medicine is genuine or not, because at the back end, those information have been loaded by the manufacturer who are working together with Check It. So it's easy to say, look, this medicine I'm buying is not listed. The batch number does not exist with the manufacturer. So, it's likely a fake medicine.
Thank you, Emeka. Appreciate
Okay,
that.
just to add to what he said, I think there's been significant improvement with authentications mechanisms on most medications that exist out there. You find for not all, actually, for most anti-malarials, and I think a lot of antibiotics that exist in the market space right now, you have a scratch code, and they're usually free of charge. You can send an SMS to verify if this is from the original source. So you just send an SMS when you buy that medication. Please look out for the scratch code. You scratch, send. It is unique to every individual pack. Once you send, you can get a response to confirm the authenticity of the medication before taking it. Once you don't get a response, then the authenticity of that medication is in doubt.
Thank you so much for that, Victor.
Yeah.
Got a question perhaps for Kwesi, a question from ED. What has been mPharma's key success factors that help them scale from 20 to almost 200 PPMVs in the Bill and Melinda Gates Foundation supported program? In a free market model, will it work, is the question.
Yes, thank you. I would say, of course, what has worked for us, one, it's the first thing I'll mention will be funding, which is why we are here today, because we had the funding to be able to scale to this magnitude, right? So that's the first thing. And I think maybe we need to start looking at it from the top, right? From the policy making level, maybe national to state level. I think Emeka mentioned something that IntregratE is doing already in that space. Looking at how to reduce the difficulty in obtaining licenses for these PPMVs. There are a lot, the criteria is very stringent. And trust me, we have a long line of PPM, a long list of PPMVs just waiting to join our network. But unfortunately, they are not able to obtain their licenses due to various reasons that maybe we may talk about later. But once we get that, then funding becomes the #1 priority for this. Because another example we can give actually is when we talk about financing, we need to also look at from the part of the microfinance institutions. Are they just financing these PPMVs from a commercial level, or they are looking at it from an impact-based financing level, right? If it's impact-based, then you should be looking at long-term financing, looking at the impact to society. So you shouldn't really be just give them, well, let's say 5 million naira, for example, and then come at the end of the month to collect your interest, or at the end of the second month, collect your interest. You need to sort of handhold them take them through, give them the financial literacy, take them through the whole process, hold their hands up until the payment is done. And I guess that's one thing for mPharma. We are not looking at the direct benefit to us. We are looking at the benefit to the PPMV and to the rural community at large. So that has been the major success factor for us.
Thank you, Kwesi. I guess that answers the anonymous question around the micro-lending apps and how they can leverage the credit financing for PPMVs. It's not just give money and take money out. It's a process. It's a partnership. It's a collaboration, and it's a long kind of journey together. Yeah. Another question from an anonymous attendee, and I'm not sure if we've answered it already, but who oversees the practice of PPMVs? Do they have a regulatory agency who monitors or audits their practice? Do they report to any of the family doctors, and are their medical records linked to family doctors? Who can kind of jump in on that, Emeka?
Okay, well, I guess this person just joined midway into the conversation. The PPMVs are regulated by an arm of government called the Pharmacy Council of Nigeria. They used to be called Pharmacist Council of Nigeria, but the new law, with the new law, is now called Pharmacy Council of Nigeria. So they are saddled with the responsibility of, one, prescribing the kind of training that the PPMVs should have, licensing PPMVs, supervising, regulating them in all its ramifications.
Okay. Fantastic. Thank you, Emeka. Another question from Oluwatobi. Question regarding inventory financing or supply. How do we navigate the logistics nightmare, especially with the locations of most PPMVs, especially in the context of lead times? So as a supply, I guess a supply question.
Okay. So let me comment that. So within 1+ years that we've been in actual distribution, presently I make bold to say that we're in 36 states of the Federation, and regardless of your locations, we have sales agents who would deliver these medications to your doorstep. So every PPMV that's subscribed on our platform, within this past 1 year, we have over 2,000 PPMVs that we supply to.
Okay, I think Victor's having some issues. Let's move to another question from an anonymous attendee until we get Victor back. Victor, are you with us again?
An efficient logistics team that delivers.
Sorry, Victor, we lost you for a few minutes.
So I was saying that we have an efficient logistics system that tackles all of these delivery system to the PPMV. So when they place this order on our platform, our inventory control process, all of these, hand it over to our logistics, and then in real time, regardless of your location in Nigeria today, we deliver to your doorstep. And we are doing that for over 2,000 PPMVs registered on our platform today. So across the 36 states of the Federation, we have sales agents across. So that is, we notice there's an enormous gap, but we are taking it upon ourselves to do all of this. Thank you.
Thank you, Victor. Another interesting question from Anonymous here. Should we be discussing regulation? Shouldn't we be discussing regulation before funding? The reason the person gives is because the majority of fake drugs come from PPMVs. Shouldn't we be sanitizing the space, excuse the pun, before discussing funding? Because we don't want to scale unethical practices. Question around ethics, around funding, perhaps some PPMVs who are not perhaps following the rules. How do you deal with that?
Okay, let me chime in. I think this is actually what we're talking about. That first and foremost, you bring PPMVs into regulation. Now, PPMV is a general term for anybody who is selling drugs for profit at any level in the community that is not trained as a pharmacist. Now, we know there are quite a lot of them, like we said, that are not registered by the regulator. not within the radar of the regulator. So, and that is why Society of Family Health, with funding from Bill and Melinda Gates Foundation, is piloting the IntregratE project, working very closely with the Pharmacy Council of Nigeria through the tiered accreditation. And one of the major anchor of the tiered accreditation is that the PPMV must be registered before even training them on mandatory entry point training, which is a tiered accreditation training. So we are getting to that point where anybody who wants to become a PPMV, and even those who are currently practicing as a PPMV, must go through that accreditation training and then must register. So as we are saying that, we are also saying that for those that are registered, how do we begin to think of supporting their business in such a way that they become sustainable, so that you don't wake up tomorrow, you don't see them there, yet you desire their services? Because like I said before, there are some communities where there are no PACs, there are no community pharmacies. So what do you then do for those communities? So those PPMVs that are already existing, get them to register with Pharmacy Council of Nigeria as a first start, let them go through the accreditation system training, and then we can now support them, financially, to make them more sustainable.
Okay. Emeka or Charity, can a question from Pfizer? Sorry, yes, Charity, you wanted to follow up on that?
Yeah, I want to add to what Emeka has just said. The question came up on registered PPMVs. Mm-hmm. How do we control their activities? Emeka has given a good insight on how their activities, how they should come under one umbrella registration by the regulatory bodies. Once that is done, to me, I think the next step is how to support them to get adequate finances to be able to carry out their businesses, especially at the local levels where communities where they are needed. So by so doing, I would like to suggest that they can also form themselves into cooperative self-help bodies to be able to advance credit facilities to them. There's also like what the government policy did on production of rice, for instance. The Anchor Borrower Scheme of the federal government is a policy that the federal government brought that could also be adopted. Government can create some fund, just to support this very important part of medical care for the rural communities especially. So by creating putting down such a pool of funds, they can access it, like we said, if they have formalized their enterprises, like we earlier said, you have their addresses, you have details concerning them to be able to recover this fund back from them at when the need arises. They can also be cluster formation for them so that they can use common, facilities, so that that will ease their delivery to the communities where they operate from.
Thank you, Charity. And we've come to the end of our kind of Q&A discussion. I wish we could answer more questions, but we are running out of time. I do want to just get some final remarks from our panelists. It's been a really, really great conversation, and I'll start with Michael. Michael, your final remarks on this topic.
I think ultimately, PPMVs are key to realization of the universal health coverage by virtue of the number and their reach. And for us to improve the services that they provide, there is need to improve their business practices. through the provision of some kind of finances. And for us to get to that point, we have to be very innovative, considering the reach and spread. So, and that is where digitalization comes in, and that is where innovation, new approaches comes in. So there are lessons to learn from other clients, and I think we must look at that and bring in those best practices that has worked in other areas, so that ultimately we can improve the overall health system in Nigeria. Thank you.
Thank you, Michael. Can we go to Victor? Victor, your final thoughts, please.
Okay. Thank you for putting all of this together to talk about PPMVs. They constitute a huge part of the distribution systems of medication in Nigeria as it is. We have more PPMVs that is established, more PPMVs than pharmacies, registered pharmacies, and hospitals put together. When an average Nigeria comes down with a basic ailment, the first point of resort is a PPMV. This is such a huge population that we cannot ignore. We need to give adequate attention to PPMVs and have more integrative approach where we can improve the overall healthcare delivery system for Nigeria. And by doing that, would also foster a very productive country and a very productive continent going forward. Thank you.
Thank you, Victor. Can we go to Kwesi? Your final thoughts.
Yeah, thanks, Adrian. I think for me, simply put, PPMVs are here to stay, whether we like it or not, whether illegal or legal. Probably for every PPMV, illegal PPMV alliances, PPMV we try to shut down, probably 5 or 10 more spring up. So it behoves on all of us to ensure that at the policymaking level, we find a more inclusive approach to get them into the healthcare space, which will then give comfort to these microfinance institutions to grant them or extend them with these facilities. So yeah, these are my last thoughts. Thank you.
Thank you so much, Kwesi. Charity, your final thoughts.
In terms of assessing credit facilities for PPMVs, in conclusion, I will recommend that there is a need for increased training, entrepreneurship development training for PPMVs to build their capacity in business development and growth. There's need for them to be trained on how to write proper business plan so that they can articulate clearly their ideas, business ideas. Record keeping is very necessary. And of course, marketing of their products is very key. Thank you very much.
Thank you, Charity. And finally, Emeka, your final thoughts, sir.
Okay, well, I'll start by saying that 60% of Nigerians, especially those who are living in the rural and underserved areas, access care from the PPMVs. 1 in 3 under 5 children are treated for diarrhea and pneumonia within the PPMVs. For family planning, PPMV provide almost 72% of family planning services and products within the country. And I think these are numbers that we should not take lightly because several studies keep showing this. So what do we then do to be able to strengthen the operations of the PPMV? And that's why we're having this conversation. How do we begin to think innovative ways to finance and support the PPMVs on a sustainable basis? Until we're able to get that, we'll keep having this issue of either poor services, fake products, and all that. So I think the conversation just began, and I want us to begin to take it forward beyond this webinar. Thank you very much.
Thank you so much, Emeka. And finally, I just want to ask if you have anything to say finally, and as a final remark, or you'd rather not. I'm just offering you the mic if you need to. If you there? Okay, maybe he's not available at the moment. I just want to thank everyone. Thank you, our audience, the attendees, and thank you to our panelists who've been so interesting in this conversation. It's been, we could go on for another half an hour to discuss this, a really important subject. But thank you for attending. It's a real pleasure to have you here. Thank you to our audience for being a part of this. I just want to remind our audience to fill out the post-event survey, which will be available to you all. And of course, none of this would be possible without our sponsors, Solina. Thank you for your support in putting this event together. I do want to ask our audience to subscribe to our TC Daily newsletter. It's a really good one, and In a Jiffy, which is our TC Insights newsletter as well. Both are really great sources of information on a weekly basis. Thank you again for joining us. It's been a pleasure. Look out for our next TC Live event, which will be happening in the next coming weeks. It's been a pleasure, and I wish you all a blessed and fruitful weekend.